No niin, hyvää iltapäivää kaikille.
Yes, good afternoon everyone, and I would like to warmly welcome you to this first session of this afternoon, which will be held in Finnish.
Tervetuloa sekä kaikille läsnäolijoille että siellä online-verkkojen päässä, ja voitte myös kuunnella tätä vierailla kielillä tulkkauksen kautta samanaikaisesti. Meillä on tänään mielenkiintoisia ajankohtaisia aiheita esittelyssä muistisairauksiin ja niiden palveluihin liittyen. Meillä on esimerkki Pohjois-Karjalan alueelta muistipalvelupolusta.
We are going to hear an example of dementia care path, and also we shall hear about self-determination. My name is Pia Pulkkinen and I work as a specialist at the Finnish Institute for Health and Welfare, and I've been pondering about working on memory issues.
Ollut muistipoliklinikalla mun mielestä töissä. Ja mä nyt aloitan myös tämän minun esityksen ja esitellään muut puhujat sitten tuonnempana. Eli minun aiheenani on tämmöinen tutkimushanke, muistisairaiden henkilöiden palveluiden käyttö ja kustannukset ennen diagnoosia. Meillä ei Suomessa ole ihan tarkalleen ollut tiedossa, kuinka paljon muistisairaita henkilöitä on. Tieto on perustunut yleensä kansainvälisiin estimaatteihin, ja kuitenkin tiedetään, että väestö ikääntyy ja muistisairauksien riski kasvaa ikääntymisen myötä. Samalla siis myös sosiaali- ja terveydenhuollon kustannukset kasvavat, ja niistä oletetaan noin 85% koituvan ympärivuorokautisesta pitkäaikaisesta hoidosta. Ja näin me saatiin sitten rahoitus tälle hankkeelle vuosille 2023 ja 2024 tästä EUn Next Generation -rahoituksesta, jonka sosiaali- ja terveysministeriö meille antoi. Ja tämä on yksi näistä RRP-hankkeista, joita THL:ssä ja ympäri Suomea tehdään. Tämän tutkimuksen tavoitteena on saada tietoa muistisairaiden henkilöiden palvelujen käytöstä ja kustannuksista ennen ensimmäistä diagnoosia, ensimmäistä lääkemääräystä tai ensimmäistä lääkeostoa. Ja näiden tietojen pohjalta pyritään etsimään palvelupolkuja takautuvasti näille henkilöille ja mahdollisesti pyrkiä ennustamaan palvelutarvetta ja kustannusten muutosta sen perusteella, mitä tiedetään väestön mahdollisesta kehityksestä esimerkiksi 10 vuoden päähän eteenpäin. Ja tässä ennustamisessa tai skenaarioiden laadinnassa käytetään tämmöistä sosiaaliturvan menojen pitkän aikavälin ennustemallia. Meillä on myös osatavoitteita. Meillä on 2 kohorttia. Ensimmäinen vuodelta 2019 ja toinen 2021. Ja näin me mahdollisesti voidaan myös nähdä, onko koronapandemian aikana syntynyt hoitovelkaa. Ja kuten sanoin, niin meillä on toiveena ja yrityksenä selvittää palveluprofiileja ennen ensimmäistä muistisairausdiagnoosia. Ja toki pyrimme sitten etsimään sieltä mahdollisia tunnusmerkkejä, että sairaus voitaisiin tunnistaa mahdollisimman varhaisessa vaiheessa. Meillä on myöskin käytössä kotihoidon asiakkaille RAI-tiedot, eli tämä palvelutarpeen arviointiin nykyisin lakisääteisesti Suomessa käytettävä menetelmä, jolla muun muassa toimintakykyä pystytään mittaamaan. Ja näillä tiedoilla sitten sinne ennustemallien taustalle hankitaan sitä tietoa. Lisäksi meillä on tässä hankkeessa myöskin monitekijäisen FINGER-elintapaintervention vaikutuksia koskevat tulokset, ja tämä FINGER nousikin moneen kertaan tuossa plenaarin aikana esille ja näiden ensimmäisten puheenvuorojen aikana täällä konferenssissa esiin. Eli jos tällä elintapainterventiolla voidaan vaikuttaa muistisairauksien etenemiseen ja toimintakyvyn ylläpitoon, niin voidaan tämän pohjalta tehdä suosituksia, miten elintapaohjauksella voitaisiin muuttaa palvelujen käyttöä. Meillä on menetelmänä tässä tutkimuksessa rekisteritutkimus, ja meillä on 2 lähdettä. Toinen on hoitoilmoitusrekisterit ja toinen on reseptikeskuksen aineisto Kelasta. Hoitoilmoitusrekisterit jakautuu avohoidon ja terveydenhoidon hoitoilmoitusrekisteritietoihin, ja THL ylläpitää näitä. Ja näistä saadaan siis se diagnoositieto. Reseptikeskuksen aineistosta saadaan lääkeostot ja lääkemääräykset. Lisäksi meillä on sitten tämä RAI-tietovaranto ja Finger-tutkimusaineisto käytettävissä. Ja nämä tiedot yhdistetään sitten henkilötunnusten perusteella, mutta kuitenkin niin, että yksittäisiä henkilöitä ei voida tunnistaa, vaan tiedot anonymisoidaan. Tässä on sitten tarkemmin kuvattuna tämä.
And here we have a sort of more detailed illustration of the cohort. We are including everyone over the age of 18 in Finland. And since our data comes from different registers in many different places, we need to investigate that everyone is recorded only once. So we only include unique persons and exclude everyone living abroad, living in the Åland Islands, and people with an unknown social security number, and people who have received a long-time care decision, and based on other people remaining are included in the research. We rely on the ICD-10 criteria for memory diseases. And the HCC codes are used to identify the prescription drugs or medication that have been prescribed to these people. Research is still at a very early stage. I hope that you would not share this information at this point yet. But it seems that now those receiving the first diagnosis or their first prescription, or people who have purchased their first prescription drug, the number is some 22,000 people. Their average age is around 80 years of age, and 95 of those people are over the age of 66. Majority of them are women. Our research group comprises employees in the THL, but we have partners in the University of Helsinki, and we also have very strong links to the University of Tampere. And also, because we are including RAI data and finger data, we have people who have been involved in both research projects, and a person who is able to produce social security data. This was my presentation in its brevity. Thank you, ladies and gentlemen. If you should have questions, please raise your hand. We do have a person with a microphone helping us here today, and you are free to present your question.
Thank you. Our next speaker is Simo Mölsä, specialist in geriatric medicine, works in the Wellbeing Services County of North Karelia in this geriatric center. Please, the floor is yours. Thank you. So SiunSote is the Northern Karelian area that I represent, and for years now we've been a so-called Wellbeing Services County since 2017, and even before that we have a centralized system how to approach people with memory disorders in our region. So we talk about SiunSote, which is the Wellbeing Services County. As my conflict of interests, I don't have any. Well, I only hold the chief medical doctor's position in the county. But then, the services we provide. We have 30 municipalities, and the population of the number is 160,000. And you see the age pyramid, mainly elderly people, so risk group for memory disorders, over 75 years of age, 20,000, and about above 60,000, 60 years, 100,000. And if you think of the chain of services, there's one point actually missing here, which is the preventive work. But our pillar for all our work are the 15 regional memory nurses. They could be called coordinators, but we use the word memory nurse. We had at least one person that has been named as a memory nurse. They work at the public healthcare centers, but they can go and visit people at their homes as well in their region. And because of resources and practical questions, it's the clinic of neurology that will assess all cases for those who are under 75, and the geriatric clinic will take care of everybody over 75. We have an assessment, a rehabilitation department, which is geriatric one, and a palliative center as well, which is participating in the planning, and of course home services, residential services, and informal care services. And if you think of the chain of services for people with memory disorders, so we're no longer the prevention, but we have a suspect of a person with a memory disease, possibly. So either the person in question or a family member or the worker takes or contacts us with the consent, of course, of the target, and they will be then given an appointment with the memory nurse. Either they come to the clinic or this is at their home. One exception to the rule is that if they already have a home care services, then usually this is done by home care services, this assessment. And as said, according to the age limit, it is either the geriatric clinic or the neurological clinic. But for younger, early suspect cases, they go to their public healthcare center, and then they see a neurologist, so a specialist, if they are below 60 years of age. So there are less indicators that can be used. And as you just saw, majority of our cases or the population is over 60 years of age in our region. So there's first, mapping. I don't have that much time, so I will not explain this in detail, but we have extensive mapping first. History of life, educational history, situation in life. Of course, the driver's license question is taken up already. And we have memory nurses, and said they usually have an oral assessment. They describe the situation, which is very informative description because they can identify these things. And a visit to home, not always possible. It's not perhaps always the right purpose, but if you have a person living alone, you can also check the home in order to get further information. And during the first visit, we will ask about whether they have taken into account of giving mandate for a legal representative, living will, and any benefits perhaps the person is receiving. And then the actual screening, we have CERET, that's the main tool for memory diseases, and the TMT for assessing driver's capability. And not perhaps during the first visit. TMT is not the usual CERET that is used during the first visit. And there's also reference to any earlier examinations by the memory nurse. There could be data from 10 years, 20 years in the past. And the ability to function, we have CUTS and later Brody indicators. You could use ADS and interviews, others as well, other structures that can describe to you the functional ability. And as for the mood, we usually have GDS 15 for that. We also have the formula for memory questions to relatives. And there are laboratory, of course, blood samples and weight, height, blood pressure, and give some steering as well. The memory nurses give some steering and also steer to rehabilitation interventions or nutritional guidance if there's a clear need to be supported through home care services during the first visit even. And after this mapping stage, there are a couple of alternatives, meaning if you first have an impression that there is something now exceptional, the memory nurse can steer the result, if the person is over 75 years, directly to a geriatric specialist. So it is the specialist in geriatric medicine who will go through the text and then make referrals to further studies like CT scan, and then asking for the clinic for a visit. Or perhaps it's not the case, then there should be some follow-up or any. And as said, the threshold is 75 years, so it's either the primary care medical doctor who will then see that, or then will refer to a neurologist. So 75 years, yes, but you can use your own consideration. You can deviate from this age limit if you have even younger patients that would prefer or benefit more from an appointment with a geriatric specialist. So it's always a bit case by case as well. It could be referred to by the primary care MD or the memory nurse or through any other ways of referral. But if there's a clear suspect by the memory nurse that there is no memory disorder at all in place, so that case there will be some follow-up or any other intervention as needed. But of course, the results have to be checked out if there are any possibilities for the other option. And what happens at the memory clinic then? So if you think of our region, the distances at worst could be 150 kilometers when they come to the clinic. So therefore you need to make this reasonable that imaging, all examinations are done once you come over, everything at once. It means that the patient comes a long distance away, first as a head scan, radiologists give the statement immediately, and then memory nurse has a control assessment, and the specialist in geriatric medicine will also meet the patient. And usually the real life is that there will be several months from the first mapping before you have an assessment appointment at the clinic, and therefore you perhaps have a change in your physical ability, and that information of course is needed. So once the geriatric medicine specialist is there, so you of course take into account not just the memory disease but all ability to function or medication and everything that can have an impact on memory disorder. And living will as well is discussed even during the first visit. And of course we give them the diagnosis, we plan and assess the further steps, and of course we then steer to interventions if needed and if they were not yet implemented. If needed, we can ask for further imaging, metabolism, psychiatric statements, or liquor, and different type of sampling if needed. Then the follow-up. It's usually individual follow-up, but we do have a protocol in place for this. When you want to have the diagnosis, you start the medication. There's a routine call once after one month, and then usually after 6 months and 12 months you come to the appointment every year, and we go through same topics as during the first visit: intervention, steering, informal care, assessing that as well, everything that is needed. And the MD, the clinic, when needed, will assess driving capacity of the person. And after 1 year, or more or less, you would, yes, meet the MD. But currently, the real life means that it's only when needed, when the driver's license test is conducted. But if now or later, the home care or in the residential care, there the follow-up will be implemented, of course, by that home care or by the physician who is in charge of the residential home. Then the neurological clinic. I worked there a few months myself. They do more similar things there as well. The early part follow-up is done by neurological clinic, and after 1 or 2 years, perhaps then even at the early stage, it depends on the assessment, they come to us for follow-up or through their home care services or residential home care services. But if you think of this clinic, they of course can give a diagnosis, and they have resources, rehabilitation workers, social workers, everybody can be done after this by themselves as well. And as said, we have also assessment and rehabilitation department with 12 beds, and I think the number could be higher. And I have to say that we check out there everything, diagnosis, if there are some unclarities, behavior is evaluated, if there are challenges to functionality of the person, any rehabilitation needs. And the point is to support that they will manage at home, and also supporting the informal caretakers and thinking of any risk of falling down at home, going through these essential things. You can come to the rehabilitation for 1 week or 2 weeks. It could be shorter or longer. We have a discussion at the end of every section so that the MD is there, giving some steering, and employees of that particular at the ward are specialists in memory disorders. There's a physiotherapist several times per day, or the functional therapists as well. So you do have specialists who are there almost daily. And also neurologists, as said, a couple of times a day, or rather a week. And we have also meeting with the other clinic. So there are joint meetings. So this is the holistic juristic assessment, and based on this, we will plan interventions. And the end of life. This treatment is also taken into account. Usually it's in residential homes with 24/7 services. We call it enhanced service living. Not home that much. Well, of course, it's very extremely valuable to have people at home with informal caretakers, but now we talk about the responsibility by the primary healthcare doctors and consultations to the palliative center or geriatric center. But if you have a person living at home and you have the treatment end of life, then it's usually the palliative center that is involved. And I would say the situation is positive because we at 100% could say that we have a proactive caretaking plan for all of our residents, meaning residents who are within the scope of residential homes. We call this the health and caretaking plan. We have an abbreviation for that as well. It's a document that contains all long-term information related to the ability to function, any restrictive measures, how to react to an acute situation. So, and this is visible to everyone. The specialized care, primary care, it's the same patient data system that contains information without limitations. If the ambulance calls, then the person on call can see the different path of this plan, what has already been planned in ahead.
Vuorokauden keskeisellä alueella tarkoittaen 20.
Within a distance of 25 kilometers, where more than 50% of our population live, we have a home hospital care service that can provide hospital-like care even in the care home. Also, we have a first response unit with one nurse that can cover a large amount of our population. And in Joensuu, we have a so-called palliative center with a palliative clinic with a specialist palliative department where sometimes, if need be, there is such a unit exists. And also the first response palliative care protocol was originally, in fact, developed in North Karelia in our palliative care center. That was it. I myself have not been involved in the most recent update for this year, or for last year, but I have been involved in the new update for this year. You can see the names in there, and also there's the online address where you can find more information about our service chain and care services. Thank you for your attention. Thank you. Now it seems that there are questions for Simo Mölsä. Go ahead.
A participant here. I'm a neurologist from Germany, Bavaria. Thank you very much for your very nice presentation. My short question is, you mentioned that you make the CERAD battery in patients with memory disturbances.
Yes.
Is the CERAD done by the memory nurses, or is the CERAD done already in the memory clinic?
It's done by the memory nurses. Yes, in the first contact that they have, we use the CERAD. Yeah.
And they do it by PC, they have electronic data input, or how they?
No, by paper actually. Yeah,
Paper
and we
work.
scan it. Yeah.
Koska tuo potilastietorekisteri ei salli tietokoneen käyttöä tässä. Saksalaisessa meillä neuropsykologit tekevät tämän saman arvion. Ja tämä on hyvin mielenkiintoista, että teillä se tapahtuu vähän eri ympäristössä.
So I think I'm the second person who doesn't speak Finnish here.
Toinen ei-suomenkielinen henkilö. Haluaisin kysyä vähän tuosta testauksesta, kuulla lisää. Kuinka paljon noita lähetteitä teille tulee? Tuleeko sieltä aina lähete eteenpäin vai mikä se osuus suurin piirtein on? Ja viimeinen kysymys. Tiedän, että teillä tehdään Suomessa paljon hoitotyötä ja varmistetaan, että kaikki saavat hoitoa. Mutta onko teillä nähty sellaista, että tätä alkuvaiheen hoitoa siinä heti diagnoosin jälkeen pyritään tehostamaan vai miten? Minkälaisia tulevaisuuden suunnitelmia Suomella tässä suhteessa on? Kiitos. Ensimmäinen kysymys liittyy biomarkkereihin. Me käytämme CSF-markkereita sieltä neurologian poliklinikilta pyydetään näitä ja se on se, mitä me teemme. Jotain tällaisia hermosäie-tutkimuksia kenties myös. Ja toinen kysymys liittyi, anteeksi taisi jo unohtaa. Eli tuohon terveyskeskuslääkäriin, yleislääkäriin, lähetteisiin. Jos sillä epäillään muistisairautta, niin silloin yleislääkäri ohjaa potilaan muistihoitajalle. Ja se on tavallaan se polku, se hoitopolku, jota siinä noudatetaan. Aina käytännössä potilaat ohjataan alkuvaiheessa muistihoitajalle, joka sitten ohjaa heidät eteenpäin esimerkiksi neurologille tai erikoislääkärille. Ja kolmas kysymys liittyy lääkkeisiin ja varhaiseen diagnostiikkaan. En oikeastaan osaa sanoa, että mitä tuohan voisin sanoa. Meillä ei niitä niin paljon käytetä. Pyrimme tietysti tällaiseen varhaiseen diagnoosiin koko tässä mallissa, joka meillä on, tai tässä hoitopolussa. Oikeastaan siinä kaikki, mitä voin tässä kohtaa nyt tähän vastata. Hyvä kysymys sinänsä kyllä.
Suomeksikin ottaa esille tärkeitä asiaa. Ja tämä on
things that you talked about and how to access the world of the person living with dementia, that would be crucial. I think the British have an excellent saying for this. Only the wearer knows whether the shoe fits or not. I cared for my wife Eva, who was living with Alzheimer's. I cared for her for 18 years, and 2020 she left us. And last summer I started writing a book, because whenever I talked somewhere, I told that Eva is the one who speaks and I'm just the interpreter. And I think I still feel like this. And when I thought about our lives, how much help and support we received from various directions. And I invited 30 of all of those people who helped us during her illness to help me give feedback for my book. And last year I published my first book, and now on the 10th of October I published my second book with this sparring team, with their support. And Eva is still the one who is speaking. I am just the one who is interpreting her thoughts. It is very difficult to write a book that would be useful and also interesting enough so that people would like to read it. And both books are written in simplified Finnish. But also in the second book, the typeface is bigger, the font is bigger. I have abolished hyphenation, and it seems that it is very much easier and nicer to read. Because when you're living with a memory disease, people find reading very tiring often. And here, with the simplified text, with the simplified language, with the simplified layout, and with lots of pictures, then it is easier and nicer to read. And if you can't figure out one picture or photo, you can move on to the next one. Mari Kunnas is a children's author, writer who's familiar to all. He draws in such a simple way that his work doesn't require any further explanation. And his drawings are very popular and only used in his books. And I contacted Ottawa, the publishing company, and I asked whether I could have a picture from him. And they responded that they will contact Mauri Kunnas himself directly. And the next day they sent me a message that my work is so valuable, he will release the picture of a mill for my book without any cost to us. And that was excellent. I would really like to thank the publisher and Mr. Kunnas as well. Thank you. Maybe we should move on? Oh, there's room for one more question. Can you hear me? Henabri from I'm a memory worker in the Koillismaa region. You talked about your division of labour, or the division of ages under and over 75 and over 60s. I think this is exceptional compared to the rest of Finland. You talked about the reason behind this is allocation of resources, but have you noticed whether this poses challenges, or is it beneficial to your organisation or to the client? What are the outcomes? Very often the person with dementia, the path is not so clear, not even in the organisation. I know that different areas in Finland, they set the limit at 65 years or 70 years of age, and also 75. We're not the only ones using that age limit as a divider. But we feel that this is a very good point to divide these patient groups. And perhaps it could be lowered down to 70 years. That might be, obviously, as I said, we apply this divider case by case basis. So we use consideration individually, but maybe lowering it down to categorically we couldn't cope with, because we don't have so many geriatric specialists available in our welfare services county. So that's why we have set the limit at 75 years of age. Thank you. As a researcher, I'm interested in numbers. Pia mentioned the number 22,000, more or less, 22,000 diagnoses in Finland. And I would like to know, can you give me any numbers from your welfare county, the SiunSote area? Maybe not the number of diagnoses, but how many people enter this investigation stage or are suspected of living with dementia, and how many of those who start following your care path, how many of those are people who actually do receive a diagnosis, maybe in a percentage off the top of your head? Well, it might have been a good idea to actually look at the numbers and figures. I don't dare give you any specific numbers because it would be guesswork. Obviously, we conduct hundreds of studies and every year, and the line, people waiting in line to meet the memory nurse is 200 plus people every year. But unfortunately, I cannot give you any more specific numbers. We can return that later on. Yes, thank you. Thank you very much, Simo Mölsä. And thank you also for your questions. And now we are going to move on to the last speaker or presentation. It's given by Johanna Edgren. She's a doctorate in health sciences and a physiotherapist, and interested in the prevention of health. We shall now hear from Johanna. Thank you. Like Pia said, in my previous life I used to work as a physiotherapist, and I'm sure you can hear and see that in my presentation. At the moment I work as a senior researcher at the Finnish Institute for Health and Welfare, THL. I will present my results. Some of them are published already, some of them are unpublished preliminary results, particularly those linked to self-determination and to how aging people and how can we utilize their resources, their personal resources, or do they receive support? There are 2 studies. First of them is a published study. It was published last year, in fact, and it reflects on self-determination in home care and round-the-clock assisted living or care home living. And the other research is an unpublished one, conducted by me primarily. And here we are looking at the resources and how to support those resources in round-the-clock care setting. As a researcher, I'd like to share background. Why did we study certain matters? Obviously, we've heard about the importance of these matters already, and the quality recommendations from the Ministry of Social Affairs and Health. They also underline the importance of identifying and supporting the resources and promoting their inclusion and participation. The WHO has underlined the importance to support people's ability to live at home, holistic care, rehabilitation, and sufficient support for the person living with dementia and also their families and the people caring for them. They should be emphasized even more than they are being emphasized today. And also, as I've seen the RAI data, the Finnish Institute for Health and Welfare, the same phenomenon can be seen even in their many clients receiving round-the-clock care. They have resources, but they do not receive enough support for them to maintain those resources. A lot of research has been done on how aging people living with memory diseases benefit from rehabilitation, whether we're talking about their ability to cope in their everyday life, cognition, use of services, falling incidents, etc. There's a slight conflict between this piece of information and the recommendations from the Finnish Ministry of Social Affairs and Health and the HWO. It is quite common to use restrictive measures for people who receive or who have been diagnosed with memory impairment compared to other patients receiving 24 around-the-clock care, which is unethical and not very, you can even question whether or not the basic human rights are being respected. And some of the concepts and terms that I will use in my presentation: living will an individual indicates clearly what kind of care they will receive at the end of their life. Nursing care supporting rehabilitation means that the client is being supported in using their physical, mental and social resources as part of their everyday nursing care that they receive. And the RAI abbreviation mentioned already, the resident assessment instrument. And in Finnish, this means a tool for assessing the ability to function and the need for services, and it has been mandatory from the beginning of April this year in Finland. Here is a visual representation of the content of the RAI instrument. What it means, what is obligatory, mandated by law, for instance. You evaluate the health functionality, the use of services, medication and other factors, and the idea is to create a common ground for care and services to be able to best meet the needs of the client. The research questions, there's a number of them. I will not go through all of them in a detailed manner, but I will mention some main concepts. For instance, how well the self-determination right is realized, what kind of restrictive measures are being used in home care or in round-the-clock nursing care setting. And to what extent the cognition of the person with memory disease is linked to the use of restrictive measures, and also how well rehabilitation services are provided in assisted living setting. We don't have this information from home care setting, unfortunately. It is not available to us, so we cannot have been able to research that. And also we've compared the differences between the private sector and the public sector, and what factors are linked to how well the support for rehabilitation is actually implemented. We receive RAI estimation data mainly from 2021 and also from 2022, to some extent from another research. And this research that focuses on the right to self-determination, it is limited to people with memory diseases or memory impairment. And the latter research, we included everyone over the age of 65 years who had been received a RAI assessment, who are in a 24-hour care setting. Another visual slide. We look at the self-determination right for aging people. There are differences between home care and nursing care setting. We all know that it is quite difficult to get into a nursing care setting, and if you are awarded a place, you have severe impairment, cognitive impairment, and many other pain, for instance, depression and comorbidities. But a living will is quite as common between the two groups in home care setting and in an institutional settings, and 1/3 of all of the people do have a living will. And a donee or legal guardian is appointed for some 25% of people living in a institutional round-the-clock care setting, compared to 18% in home care people setting. And participation in evaluation, it varies between 75 for people in home care and 53 in a round-the-clock nursing care setting. And the participation of the loved ones or family members, so it's regrettably low, that figure in round-the-clock. Some around 10% of our clients, the voice of their loved ones is heard when the need for services and their functional ability is evaluated. So that's where we still have a lot of work to do. Well, in the home care setting, the similar number is almost 35%, which also is quite low in my view.
Lyhyesti sanottuna
on this picture, but the message here is that when you have impaired actually self-determination, as you have more impaired cognition, so the more severe impaired cognition you have, the more frequent was it to use restrictive measures. And maybe this was a piece of information that could have been expected as such, but yet it really, when we saw this, it was quite of a surprise. The 3 pillars up there described how many, or the percentages rather, of people who had something that will stop them from getting up the chair, and in the middle it's the restrictive means not to move their body, and the lowest 3 pillars as for the percentage of people who had boards on the sides, so everything that was open around them. It means more severe the impairment of your cognition was, the more you had restrictive measures around you. And here, to summarize everything, I have listed out that you have deterioration of self-determination rights as you had increased impairment of cognitive ability. There's more and more use of legal representatives. You don't participate in your own RIA assessment. There was less setting of goals and, of course, less functionality. This picture illustrates to you the conflicts that we can see when you think of elderly people and 24 care setting resources being used. It means that, if I could just use the pointer, as you have a look at these columns here, this is belief in rehabilitation. It means that the client themselves or employees, the caretakers, say that there is a possibility to rehabilitate the individual. And you have the level about 50% or so. And then, according to RAI, you need a lot of resources. You have a lot of resources for rehabilitation, and about 60% of them have that. And this is all national. This is the national level, green, and then the public sector is blue and private sector in orange. But as you move forward, help from rehabilitation or specialists at most received only by about 25%, at lowest 10% of the population. Think of the public sector data. And then majority of the clients do not at all have any activities. They're not involved. Or then they have very scarce care work supporting rehabilitation. So these numbers don't look very good. If you think of this table, the key message here is that if you tackle in detail the individual factors and the link to caretaking and the implementation, what is red here is the key point. The lower cognition levels you have, the more pain you have, then the probability is lower for you to get enough of rehabilitating care work. So really this makes you think. Then I would like to summarize with a few points what I have shown to you so far and what I've shown in the tables as well. The harder the cognitive impairment is, the lower inclusion and self-determination rights were being implemented. So it was a low degree of supporting their resources and inclusion compared to the resources that the person has according to RAI assessment. And on the other hand, last point what I wanted to make is that the care work supporting rehabilitation, to be exact, the likelihood of that care work was diminished by a weak cognition or impairment and pain. And there were differences between the public sector and the private sector. And I would bet that the self-determination right related questions will be highlighted even more in the future in the care for the elderly. And I'm sure that this is for a reason. And that is also one of the reasons why we wanted to tackle the right information and go into that deeper. Self-determination right and inclusion being supported is extremely important. It is important because we all know that there is a concrete link of this to elderly persons' capability of functioning and the quality of life. It means how they are part of their everyday lives, how they can be included in their lives. We also know that there is a risk for having lower capacity, or ability to function when you have a memory disease. And the pictures that I showed to you, or tables rather, I showed to you with plenty of numbers and red color, showed you that the caretaking work to enhance rehabilitation is not implemented with people with memory diseases. We furthermore saw that the loved ones, family members, and other people around them, or the client themselves, they are not always included when conducting RAI assessment. But then motivation is usually found when you yourself feel that I am included, also family members, loved ones understand the whole point, and thus they are better committed to the treatment because they are included in the planning. And quite often we also hear people say that, well, they have memory disease, severe cases, they no longer can tell you what they want. Well, I dare to disagree with that statement. Even if you have severely developed, let's say developmental issues, whenever you do RAI evaluation, with these clients, we can ask what they want, what are their own objectives, when you have the ways for that and get the time to do that. There has been a debate on that, as with the nurses and physiotherapists who are specialists with people with memory disease, and they have shared the same view. There are means once you just introduce them in practice. Thank you so much, and we have some time for questions as well. We have some questions. Okay, I will be here to answer them. Thank you for your good presentation. I'm Sevilla from the Social Ministry of Health and Services. I would like to ask, well, first of all, I hope that we will get self-determination question promoted through legislation in the ministry. That's my first point. But my question to you is, now as we're going to reform the legislation, that there will be no more diversity in the elderly care services as for employees, there will be more sort of nursing aides and helping labour force there. So do you think there will be more caretaking work so that there will be improvement of the status of elderly people? Well, thank you for the question. But about self-determination, there's a colleague of mine, Marielta, who is the directing researcher, who is involved in the drafting of the legislation. So therefore, we are following what you do in the ministry. And if I believe there will be something improved, yes, of course, I want to believe that there will be improvement. But as I've been a physiotherapist myself, I've been launching as a rehabilitation services in the 24-hour care setting in Helsinki City. And it was 2005 when I started, and I'm still a researcher, I'm still talking about the same topic. So it is not sufficient. But yes, well, I hope that it will be implemented with all those reforms and they will be fruitful. Oh yes, and one more comment. You raised the quality recommendation up at the beginning of your presentation. 2024, there will be the next version out there, hopefully already December. And there will be a priority given to rehabilitation, active rehabilitation. So I hope that the counties and the municipalities, as it's meant to all stakeholders, the quality recommendation will be taken into account, that there will be cooperation taking place and thus promote well-being and rehabilitation. Yes, indeed. Thank you. Nice to hear that you have that message on board. It's not a question, but a comment. I'm from Riken from the Development Services Association. I'm happy that you said there's a lot to learn, because yes, I agree with you. I've been learning about this. I have one diploma, and I've been working with the people with disabilities for 20 years. And I've seen that there's so much to learn from people with different mental disabilities, how to get your voice heard. And we have a lot of people who have never spoken any language, and yet how can you still hear their voice, who can't express themselves in words if they're intellectually disabled? So if we're now talking about people who had a good level of cognitions, they have the ability to speak. So therefore, I would like to see the learning from each other as for people with intellectual disabilities. Thank you. I fully agree with you. Thank you. I'm Katerina Sovi from the Finnish Society of Alzheimer Society. I, yes, agree with you as well. And in our society, we have development project on, where we have people included from the sector of intellectually disabled persons. And indeed, we have been seeing different ways how to interact, and hopefully now we can enhance self-determination. I think we have time for a second question for other speakers as well, Pia, Teija and Simo. This is a more extensive question, as this is going to be quite of a, well, not a reform of services, that would be another topic, but the change with the well-being services counties. And what is your assessment? I heard from your North Karelia, SiunSote, I saw that you have processes in place, it all works, and you have great models, but I hear messages as well, because this is a new county system, job descriptions are new, it's a transformation. So people, I know it's an odd question, but how do you assess yourselves from the perspective of well-being services counties? What about building service chains? How does it look to you? please. Right. Well, in our case, we did this already in 2017. So ever since we've been using this model. I was not drafting it, but I would say key persons came from the right places to discuss the things, and this was the outcome. I think there are opportunities to cooperate, and I would say that is the thing. I hope the energy is not consumed due to regional disables, but people would understand the big picture and think together what to do. And as I said, this is now starting with the new counties, and I hope that everybody else can do the same. Thank you for your questions. Thank you, speakers. And of course, in our project, the Memory Path, we will also take into account things and give you recommendations. So throughout this afternoon, we saw the path from early detection up to diagnosis and up to the self-determination rights of the people. Thank you so much for coming here and have a great conference. Thank you so much.